pack? Didn't I? All right, I thought we had a curved small Metzenbaum. Yeah. Hi guys, this is Charles. I'm one of the surgeons at the Animal Emergency Centre, Melbourne, Australia. We have a little dog who has a history of severe hip dysplasia in both hips. It presented stiffness in the back legs, it shakes, it tremors, it's reluctant to jump up on things. Radiographs showed severe degenerative joint disease, and on palpation there's a lot of pain and crepitus. If you haven't already done so, please subscribe to our channel. Make sure we turn on notifications so you'll get a ding on your phone the next time we live stream. So we discussed options including total hip replacement and femoral head and neck excision, as well as conservative management, which would be weight restriction, exercise modification. It's already pretty skinny, it's already being rested. Anti-inflammatories, and the owner does give it meloxicam, and cartilage protectants. It's already on Antanol, and it still wasn't working well enough, so the owners have decided to go ahead and do the femoral head neck excision. So that's what we are doing. So I'm doing a cranial lateral approach to the left hip. So I know that some people do just a linear incision heading back in this direction. I do a curvilinear incision because that's how I was taught. I find that that works well for me. So basically the horizontal part of the incision is going to match the demarcation between the superficial gluteal and the tensor fasciae lata, and then the vertical part is on the leading or cranial edge of the biceps muscle. So this is, can I get the cautery turned down please a bit? 2020 please. So I'm just coming kind of at the caudal end or caudal edge of the tensor fasciae lata, which is right about here. And then this is kind of going over where the demarcation between the superficial gluteal tensor fasciae lata is up here. Okay, so that's fascia lata right there that I'm pulling forward. And then this is superficial gluteal and tensor fascia lata right there. And then deep to that we can see our middle gluteal here, and that is tensor fascia lata right there. So reflect that distally, and then underneath that you can see the vastus lateralis right there. So now to review our anatomy, we've got vastus lateralis right here, middle gluteal there, superficial gluteal there, tensor fasciae lata is down there. Do we have Homans? Get me a cup. Yep. Yes, please. And then deep to the middle gluteal, we'll see our deep gluteal. So that's middle there. That's vastus lateralis right there. And I'm still looking for my deep gluteal here. Just kind of separating the middle gluteal up like this. And this is really severely arthritic. So there's going to be a lot of fibrotic change, which may affect our anatomy a little bit. All right, so I can feel the wing of ilium right here. And just trying to get... Okay, so I'll just reflect that dorsally there. So I'm pulling the deep gluteal dorsally. All right, and I can already feel the head of the femur right there. So that's really arthritic and knobbly looking.
It gets in the way.
Okay, so that is all joint capsule right there. Okay, so that's really, really big and thickened. So now I'm going to come all the way down to the acetabulum here and cut that, and that's going to expose the head of the femur, head and neck. All right, so now I'll just try to develop that separation between the head of the femur and the joint capsule. See if I can luxate that now. So that's luxated now. So we can take that out. So you can see how flattened that femoral head is. And then I might try to reflect that vastus lateralis caudally there. And I'm just going to try to establish that the margin of our approach there. I've got joint capsule there that I'm going to have to try to push up. Okay. And then reflect some of the vastus lateralis down from the neck here. And then we'll get a Homan up over the top. And the key is going to be trying to separate all of that degenerative joint disease from the greater trochanter, because I definitely don't want to cut off the greater trochanter. Hold on to that, please. You can let go of that. And then I'll have another Homan down here. Okay, so now I've isolated that femoral head. And I'm just going to try to clean that up a little bit. So that's joint capsule there, and I'd like to keep my joint capsule intact so that I can suture that back together, because suturing the joint capsule over the acetabulum is really helpful in preventing bone-on-bone contact. See if I can pull that back a little farther. There's a bit of joint capsule up here. All right, and then I want to point the stifle basically directly at the ceiling. Okay, I might take that out, bring that around here. All right, so my greater trochanter is right here, right? So that I don't want to cut off my greater trochanter. So I can even do a two-part cut where I do a vertical cut up here and an oblique cut down here. I think that's what I'm going to do. So I'm really trying to avoid, I want my blade pointing straight at the ceiling. And Mia is protecting my middle gluteal. Let me just get that in a little deeper. Okay. Okay. And I have actually heard of somebody cutting the sciatic nerve doing this. Don't know how they did that, but... Okay, so now that's cut off, and I'm going to remove the attachments to the joint capsule as close as I can to the neck so that I can keep those and close the joint capsule over the acetabulum. So I'm just reaching in here and cutting the joint capsule right off the neck. Okay, so that's the head of the femur right there. And I'm just going to palpate the neck. See, that feels great. And just try to reflect that down like this. And then take that out here. So that's middle gluteal up there. Let me just see if I can bring the camera right over the top. So it means my head will be in the way more, but it also means that you might be able to see what I'm doing a little better. Where are we? Here, 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 there. So that's looking right down into the acetabulum. Can I get some saline, please, and suction turned on? So that right there is joint capsule. Look at that beautiful joint capsule that we've preserved. I've got lots of joint capsule down here, so I'll be able to close that right over the top, which is going to reduce the likelihood that we're going to have bone-on-bone contact. So I'll do just a little lavage. Can I get some 2O PDS, please? Yep. I have done an epidural on this dog for pain relief. Yeah. 2O. All right, so I'll come around here so my head doesn't get in the way. All right, so I'm getting joint capsule right here, that really thick, lovely joint capsule. And joint capsule down here, which is less thick and lovely. It's actually going through some and see how I'm pulling that across to cover the acetabulum. My line for my osteotomy is exactly on the cranial caudal plane and goes from the point just medial to the greater trochanter down to just proximal to the lesser trochanter. You can remove the lesser trochanter. I like to leave it attached because that's where our iliopsoas muscle is inserts. So I'd rather leave that there. But if I'm concerned about bone-on-bone rubbing, I will go ahead and take that off. I actually have a really good course that I've created on femoral head and neck ostectomies. which if anybody's interested, you can reach out to me. My email address is ckuntz or z1@mac.com, and I can put you onto the course sign-up sheet. So it's a great course. I also have a course on toggle pinning for hip luxations, and have axial pattern flaps and total ear canal ablations, a bunch of other ones. So I'm reopening that school that I created previously. So if you're interested in any of those courses, you can certainly reach out to me. Again, it's ckuntz, the number 1, @mac.com, and I'll tell you how to sign up. And there are lots of videos and instructions and checklists and all kinds of things. So that was my COVID project, was creating that e-learning platform. You should never have to cut the middle gluteal muscle. You sometimes have to cut the deep gluteal muscle. And this Homan that's dorsal to the acetabulum, you do have to be a bit careful because you could impinge the sciatic nerve inadvertently with it. All right, go ahead and remove that. Yep. All right, so I did not have to cut my vastus lateralis. So all I've cut really is the separation between the tensor fascia lata, the superficial gluteal, and the leading edge of the biceps muscle. I do let them walk straight away. I encourage activity because I want this to be nice and pliable, this scar tissue, and I don't have any crepitus here at all, which is great. So that's one of the main causes of failure with these, is leaving the neck of the femur too long, and then you get bone-on-bone rubbing. So now I'm going to close my superficial gluteal to my tensor fascia lata here. Dee, can you remind me, please, to put my email address in the description? Sure. You can probably scrub out if you'd like, Mia. You're welcome to stay, but you can scrub out if you've got stuff to do. So Mia... Mia is our guest surgeon this afternoon. Mia is one of our nurses. Cindy, our intern, is on holidays. Didn't know holidays were allowed when you're an intern, but there you go. Disgraceful. So I'm just closing that superficial gluteal. That's tensor fascia lata right there. And when I round the corner, I'm going to be going from biceps muscle to tensor fascia lata, which is what I've started right here. Can I get some 3/0 PDS, please? So that's leading edge of the biceps muscle there. Fascia lata is there, or tensor fascia lata, coming into just fascia lata down here. There's a question about the ventral approach to a FHO. I have done them that way. My preference is the craniolateral approach. I think you get much better visualization. The exception to that would be I sometimes do a ventral approach to the hip if I'm doing a ventral hip luxation, or caudal ventral hip luxation. So most of them are craniolateral, but some of them are caudal ventral. If they're caudal ventral, then I find that I have to disrupt normal anatomy a much less, or to a much lesser degree, if I go ventral, and I find that they are often walking immediately after surgery. All right, so now I'm just going to do a deep sub-Q closure. which is here. And like before, if I haven't answered your question, just stay on the live stream and I'll go back and answer all the questions that I haven't answered when I'm finished suturing. But because I don't have Cindy here to close my incision, I can't stop now because Mia doesn't want to close it. I asked, she's not interested.
Try, but I don't know how it's going to end up.
So just a sub-Q layer here. We're basically just trying to reestablish all of the normal anatomy. So things that are supposed to be sutured together, or things that are supposed to be in one piece are sutured together, and things that are supposed to be gliding are left separate. And then I'll just do an intradermal suture layer to finish up. Yeah. Glad you stayed, Mia. I think there's a song. Do you want me to start singing a song? It would be a bad 70s song because I already have one in mind that would be perfectly appropriate.
I'm really, really, really grateful that you asked my opinion.
No singing. Just because I can't sing doesn't mean I don't sing.
Try.
Yeah. Did you see the Barbie movie? When? Yeah.
Yes.
When Barbie says that Ken is playing guitar at me. Playing guitar at me.
Yes.
Suturing from the end of the table so I don't get my head in the way. So as far as stopping bleeding is concerned during surgery, the number one thing, first thing you do is apply pressure. That's going to stop the vast majority of bleeding. Even if you have a hole in the aorta, if you put pressure on it, that bleeding is going to stop temporarily. And hopefully what's going to happen is that you're going to start getting some clotting, and that's going to slow down the bleeding enough that you can have a look and see what's going on. There are very few vessels in the body that you can't clamp. Like even aorta, as long as it's distal to the kidneys, in a life or death situation, even if it is cranial to the kidneys, you can clamp off the aorta. You can't tie off the vena cava cranial to the kidneys long term, although now there have been studies that have shown that even with that, you temporarily get some real hemodynamic problems, but then they redistribute the blood flow through the azygos vein. You can clamp the femoral arteries, the iliac arteries, radial artery, axillary artery, carotid artery. You can clamp all of those. Certainly in dogs and cats, you shouldn't tie off the carotid arteries, certainly not both of them like you can in dogs. you can, the portal vein is non-negotiable. You cannot tie off the portal vein. You will get immediate and fatal portal hypertension. Mesenteric arteries, cranial mesenteric, I don't think you can clamp those off. So again, first thing is pressure, and then try to hold pressure for 5 minutes, and then have a look and see if the bleeding has slowed down. If it hasn't slowed down, just repack it. You can try to stick something like gel foam in there or something like that to try to help support a clot formation. The other thing that I've done several times is if I have bleeding that I cannot control, I'll actually just pack it off, close it up, come back the next day. And I've never had a case that I've done that on that has not stopped bleeding by the next day. So you go back in the next day and you have a nice clot formation. You just go in and remove your sponges, finish doing what you started, and then you're in good shape. So again, the number one thing is packing it off. Number two, use something like gel foam or collagen or something like that. Number three, like if you can identify the vessel and it's not a critical vessel, you can try to clamp it with hemostats. And then number four is to pack it off and leave it packed off overnight, come back in the next day. And I'd rather, even if the owners aren't prepared to pay for that second surgery, I'd rather absorb the cost of the surgery and have a live patient than have a dead patient. All right, and my sutures are a little bit spread apart there, so I'm going to go and put another suture in that space. I did a bad job right there. I'll just put in a little simple interrupted because we'll get this dog back for suture removal anyway. All right, so that's it for me. I'm just going to go back and check to make sure there aren't any questions. So if you have hypotension during surgery because of blood loss, in addition to stopping the bleeding, the other thing that you want to do is give a big fluid bolus. And usually we start with 10 mils per kilo up to 90 mils per kilo. If you've lost more than about 20-25% of blood volume, you might think about doing a blood transfusion. You can also look at things like pressor drugs, noradrenaline, dopamine, dobutamine, things like that. I will put the email address in the description. I do still confine them for about 2 weeks, but I do encourage them to take walks and have physiotherapy and that kind of thing. You can smooth the edges with a rasp or a rongeur. It is a dog. I'm sorry that if I said cat before, I'll change that. All right. Well, if you haven't already done so, this has been recorded, by the way. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. We'll see you again soon.